Hello, everybody. Thank you for joining us today. Today, we will be presenting a webinar on removing barriers and facilitating access, improving healthcare access for people with disabilities. This is brought to you by the National Center for Health in Public Housing. Before we begin, this is just some information about NCHPH. The mission of the National Center for Health in Public Housing is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing training and a range of technical assistance. NCHPH is a project supported by the Health Resources and Services Administration and is a national training and technical assistance partner that is also 100% financed by this grant. The information presented today are those of the author only. This is just a kind reminder to everybody that is joining today that all participants are muted upon entry. Please make sure that you engage in the chat if you have any questions, any comments, or any promising practices or strategies that you would like to share with us that are related to today's topic. Please raise your hand if you would like your line to be unmuted. This meeting is also being recorded, and the slides and recorded link will be sent via email. And in the meantime, as we get started with the webinar, I will ask the audience if you can provide your name, your title, and the organization that you're joining us today, and the organization that you're joining us from today in the chat. Thank you. So today, for the speakers, myself, I'm going to introduce myself. My name is Fide Pineda, and I am the Manager of Training and Technical Assistance at NCHPH. We also have Dr. Jose Leon, who is our Chief Medical Officer. We will also be hearing from Miranda Figueroa, who is the Chief Development Officer for A New Leaf. We will be hearing from Michelle Garcia, who is the Latinx Community Organizer from Access Living. And we will also be listening from Ms. Wilson Campbell, who is the President and CEO of the Municipal Housing Authority for the City of Yonkers. All right, and now we'll pass it on to Dr. Jose Leon, who will be providing some background information about residents of public housing and the health centers that are close to public housing.
Thank you, Fide, and good afternoon, everyone, or good morning, depending on where you are in the country. It's such a great pleasure to be part of this conversation. We have a great panelists, and I hope that you engage and you enjoy this webinar. This is an important topic for all health centers, regardless of whether or not you serve residents of public housing. And it's going to be one of many webinars and learning collaboratives that we're doing, that we'll be hosting for the next few months. As a reminder, the National Center for Health in Public Housing is a national training and technical assistance partner, and is funded by HRSA to provide training and technical assistance to community health centers. We focus on those located in or immediately accessible to public housing, but the information is for all health centers. Just a quick reminder, the latest data from the Uniform Data System shows that in 2022, over 30 million patients were served by health centers, and 483 of the more than 1,300 communities and health centers reported to be in or immediately accessible to public housing. And in 2022, they served over 6 million patients. 100 of these health centers are public housing primary care grantees, and in the same year they serve almost 1 million patients. So there is a great need to make and we need to make sure that we are serving and we are in understanding the healthcare needs of this population. Next slide, please. The latest information that we have in regards to the demographics of those living in public housing is that we have almost 1.5 million residents living in public housing. And I would like to get your attention and go to the data on the people with disabilities. And we have a large percentage of households reporting to have at least one person with a disability. 38% of those households are reporting to have at least one person with a disability. This is extremely important because if we review national data, according to the latest information from CDC, 1 out of 5 people in the United States have a disability. So 20 to 25% of those in the United States have a disability. And when you compare them to those living in public housing are households are more likely to report a person with a disability when you compare it to the national number. Next slide, please. NCHPH analyzed some data. This is the latest data reported by patients. This is the patient survey that is conducted by the Health Resources and Services Administration. And as we can see here, we compare people receiving assistance from HUD and those living in public housing, and those HUD assisted or those living in public housing are more likely to have disabilities when we compare them to all other housing cohorts. Next slide, please. So we have different questions that were asked to the patients, and we have many of them are reporting physical disabilities. Let's keep in mind and go to the basics that we have developmental disabilities as well. Unfortunately, HUD is not reporting what type of disabilities people living in public housing are experiencing. But in this one, or at least the questions that are here and are part of the report from this survey are showing that the people living either in public housing or HUD-assisted housing are more likely to have physical disabilities. Next slide, please. Next slide. So now I'm turning the presentation over to Miranda Figueroa. Good afternoon, Miranda.
Hello, and I'm trying to turn my video back on. So I'm Miranda Figueroa. I'm our Chief Development Officer at A New Leaf. A New Leaf is a nonprofit organization in the Tulsa, Oklahoma area that serves people with developmental disabilities and autism. So we are a state agency provider. I know that providers work a little bit differently in each state, but we that's how Oklahoma works. Next slide, please. So A New Leaf's mission is to provide job training, life skills, residential services that elevate confident independence and self-sufficiency for people with developmental disabilities and autism. That is, in the state of Oklahoma, autism is not considered a developmental disability, but it is an intellectual disability. And a lot of those challenges that people with any cognitive disability face have a lot of similarities. So that's why we bring them under our fold as well. Next slide, please. So the reason that we exist and the reason that we were started is primarily based on employment. And there is a lot of conversation, and you can make solid arguments either way about which is more important, employment or housing. We believe each of those components really contribute to health. And that is why we do both. And they tend to go hand in hand, because without employment, you have no housing or not great housing. And yeah, they just rely on each other. And people with developmental disabilities have a substantially higher unemployment rate than their neurotypical peers. I think our unemployment rate as a country right now is about 3.5%, but people with developmental disabilities it's as high as 85 or 90%. So certainly much amplified. And a lot of that has to do with their training and meeting those individuals where they are to be able to have those employment services. And some of it is really opening the eyes of those in our community to provide those opportunities to people with developmental disabilities. Next slide, please. So here's why we exist in our Tulsa metro area. There are 40,000 people between a developmental disability, which in our state is identified as someone who has an IQ of 70 or below. And then you add in the 1 in 38 has autism. So there are about 43 people just in our metro area that are impacted by their cognitive disability to some degree. Some have just minor implications and some need total care. And what that leads to is 74% of people with IDD will live with their families their entire lives. Some of that, a large portion of that in our experience, is because there aren't enough resources for these individuals to safely live outside of their family homes. And so their families keep them home and safe, but that leads to a whole host of other challenges as well. Those that do live in the community, about half of our clients don't have family. They've either aged out of the foster care system or they are the result of institutions that closed decades ago, but they have no family. And so what happens is that they live on their Social Security. So they are living in places that they can afford, but where they can afford is not necessarily safe. And so the combination of lack of resources and unemployment leads to a severe reliance on social services and leads most of them to live a lifetime of poverty because they just don't have the resources necessary to break that cycle. Next slide, please. So just a short history of how we came to be. So we were founded in 1979 by a family who had a child with a developmental disability. And in 1979, there were even less resources than there are today. And they wanted something more for their child. They wanted her to have her own identity. They wanted her to be able to accomplish her own goals and dreams and have the resources to be able to do that. And they also felt that everyone has the ability to some degree to contribute to their community, and they wanted her to make her own way. So they founded a New Leaf with a basis of horticulture therapy. And there are a number of wonderful things that come with that. It improves hand-eye coordination, it provides some stimulation, it stimulates cognitive abilities, and also helps with just the emotional concentration as well. So we began with one greenhouse and 2 clients and 1 job coach, ironically, neither of which were Terry, the individual on which the foundation was, or the organization was founded. But then so we were providing those employment services, that job training. But then we noticed that a lot of our clients that we cared for in the day were going home to other agencies that were not providing the level of care that was the same as the New Leaf standard during the day. So in 2013, we acquired another organization that provided the residential services as well. And so that really gave us an all-encompassing ability to provide resources and services to people with developmental disabilities. And then in 2022, we opened The Village, which is a neighborhood designed for people with developmental disabilities that I'll tell you a little bit more in later in the presentation. So today, A New Leaf has 5 innovative programs that we offer to people with developmental disabilities, and we serve over 500 individuals and employ over 280 staff. Next slide, please. just a quick overview of the services that we provide, and then we're going to focus on the last three. So we provide the vocational training, and through that we train individuals, but we also pay them a wage at the same time that they're learning. So it's on the job training, and our goal is to always move people toward greater independence. Independence for one individual might be able to follow steps 1 through 5 without being prompted to go to the next. For someone else, it might be they took public transportation to work that day. That might be, the maximum independence that that individual can accomplish. And for someone else, it might be, I'm living on my own. I've moved out of my family's home. I need a little bit of help, but I'm doing the absolute best I can. So that is, we want to help everyone maximize whatever their capability is. And then Autism Works is a program that we offer within the public school system. We're in 6 different districts right now, serving 200 individual students from upper elementary through high school. And that's teaching those soft skills that are transferable in any employment opportunity and in just relationships too. So these are things like how to maintain eye contact. What's a good first impression versus a not good first impression? How do I keep my emotions in check so that I don't damage a relationship or an employment opportunity once I'm in that position? And then the Transition Academy is it's a school that we launched in August of 2022. And it emulates the college experience. So it is for young adults to help them bridge that gap between their school, their traditional school, into whatever post-secondary goals they have for themselves. There are only 2 outcomes with that. It is a 2-year program. And at the end of that, once they graduate, the goal is to be able to live independently. Supports are awesome. We just don't want them to move back in with their families. And then second is to have a job at a competitive wage. That might be full-time, part-time, depends on the individual, but we want to help them have that path to be able to achieve their independence. And then the last 2 that I really want to focus on today are the positive behavior support and then residential services. And within residential services, there is sort of a parallel path with the village that I mentioned. Next slide, please. So positive behavior support, 80% of a new LEAF clients, this is a little bit higher than the 60% nationwide average, have a dual diagnosis of a mental health condition along with their intellectual or developmental disability. And this presents a whole host of additional challenges. So that it's really difficult to diagnose, particularly if you have a nonverbal individual. But it's also really difficult to know which is the predominant diagnosis, particularly when there are behavior issues. So because of this, it causes barriers to employment, residential placement, relationships. It makes it hard for them to be able to focus on and achieve their goals because of the mental health condition, on top of the already challenges that they have with their cognitive disability. And what we found is that there are very few resources that are available to people with an IQ below 70. The myth that has been presented is that the programs that have been built are not designed for people with an IQ below 70. And at least in our state, the challenge becomes that the funding for those resources comes from a different pot of money than from developmental disabilities. So if you were an individual that's having a mental health crisis and you go to try and receive services from some of the resources, at least in our community, as I mentioned, that if you present as someone with an IDD before you present with a mental health crisis, they'll be turned away. They'll say that they're not eligible to help them because the reimbursement becomes from our healthcare authority rather than DHS or DDS services in our case. So that's a big challenge. And the closest inpatient facility for our population is about 3 hours from the Tulsa area. So, and there's in our research, we have found practically no expertise or best practices that have to do with a dual diagnosis. It is a very untapped area of research that we found. So in true Anuli fashion, if a resource doesn't exist, we create it in our organization. So in 2017, we received a grant to be able to launch a positive behavior support program. The challenge with this is it's small. There are 2 individuals on the team. And so we've taken an approach of more of a train the trainer type approach. So every single one of our 280 employees will receive some sort of training on positive behavior support. And this has to do with identifying what might be a trigger for somebody, the very high level conversations, and then how to just kind of, high level again, how do you get individuals back on track? We found that in most cases, it's a communication issue that our staff have done something to trigger someone inadvertently. But if we can be more aware of what might be a trigger, then we can adjust our own behavior as well. And then there might be more intense training in specific homes or with specific clients for both staff and their families if they're living with their families. And then our team does have a small caseload of the most challenging cases, so that they're receiving a little more intense support. About half of our clients receive a scholarship, and that is because even though we are able to provide this resource, almost all of our clients are on some sort of waiver service. And the way that it works in our state is 1 hour of positive behavior support. The value of that is about worth 20 hours of vocational training. And the individuals that we serve, that's an unfair decision that they have to make. They need both to be able to be successful. So we receive grants and we offset the cost of that with philanthropy to be able to provide both of those really critical services to our individuals. And we are the only nonprofit in the state that has that family training contract. The other contracts are with for-profit organizations in our state. But to further advance this without investing more in this organization, we are partnering with another nonprofit in our community called Family and Children Services, and they have the ability to bill through insurance. So we have started a pilot program with them just starting this month. It's starting out with 7 individuals who need more intense support than we're able to provide in-house. So we are really excited to see how that is going to progress over the next 6 months, at which point we will reevaluate. Next slide, please. So residential services, a new LEAF serves 103 Oklahomans with IDD to help them live with maximum independence. Some are living with their families, where we go in and we provide respite services or just general in-home support services. Or some are living a couple of roommates together. Some are what we call class members. These are individuals who were part of a class action lawsuit when a local institution closed. So they receive additional services and funding and are able to live alone. So we provide support in that arena. And then 62 individuals live within our neighborhood that we launched. These individuals are primarily funded through HCBS. We do lose, we wouldn't be able to operate at the quality and the level that we do based just on what we're reimbursed through DDS, Department of Disability Services. So about 70% of our funding comes from being reimbursed for those services, and then 30% is through philanthropy, and our social enterprise that we have. We have a number of garden centers that help support what we do. So the resources that we provide are all client-centered. What we aim to accomplish is to maximize dignity and client choice. So we might provide services on the vocational side and they choose someone else to be their provider on the residential side. It is not a one size fits all. We want everyone to have the same choices that their neurotypical peers have as well. We meet individuals where they are. So our services range from total care to with feeding tubes to just a couple of hours a day or even a couple of hours a week. We want to provide right fit services for the individual. And part of the services that are in that are transportation. That's a huge barrier to any sort of dignity or getting to healthcare services, activities, just quality of life. Transportation is a giant barrier. So we provide that. We can do medication administration, community integration. We want people to be involved in the things that they like to be involved in. We can take people to their healthcare appointments and help them set those. And then, of course, meal planning and prep as well. And to accomplish that transportation, we own a fleet of 24 vehicles that seems to be growing exponentially every single year. Next slide, please. So the healthcare coordination, we can help individuals set appointments based on knowing who their healthcare providers are, but we do not choose doctors for people. There do tend to be, dentists that people in the IDD community like to use. They've built a reputation upon that, or cardiologists that they like to use in similar ways that, neurotypical individuals will refer doctors to each other. So we don't choose doctors for people, but we do, we can set those appointments. We have nutritionists that come in and meet with staff and clients so that they are preparing healthy meals. There is helping them to make healthy choices. But again, it is based on choice as long as there aren't dietary restrictions. So if someone is a brittle diabetic, we are very aware of the dietary needs with that, but we try not to impose undue restrictions. We encourage meaningful movement through client choice. We don't use the word exercise because that tends to be negative. A lot of our clients that we serve have been restricted in their lives. And so the things that they have control over, sometimes they don't make the healthiest choice. We try and make meaningful movement fun and part of their daily lives. And we encourage healthy friendships. All of these are really important to the overall health. It's not just the physical health, but other components of health, emotional health, spiritual health, and really encouraging all of those components as well. Next slide, please. So this is the village. This is a initiative that we started in 2016 doing research. We researched a number of models across the country and then settled on a model that works best for us. So this is housing. It is housing, and it can be independent of the residential services as well. So someone can choose to live here and choose someone else to be their service provider. We haven't had anyone that wants to do that. Everybody likes the services that we provide, but the choice is always there. You'll notice that this is a big U-shaped neighborhood. This is phase 1 that sits on about 22 acres, including a greenhouse that you don't see in this picture. And then we moved our administration offices out here as well. But this is 62 units of safe and affordable housing in several different housing styles based on a person's needs and the season of life that they may be in. Next slide, please. So as I mentioned, phase one, we actually own 50 acres and we've built on 22 of those. And we completed this phase one in August of 2022. And it is safe and affordable. Two of those key critical components that have to do with housing and significantly can impact someone's health. As I mentioned, 74% of people with IDD live with their families their whole lives. This gives another layer of choice to those individuals because they were living where they could afford, but where they could afford was not safe. The other thing that we learned through our time since we acquired the residential provider and began providing those services is that a lot of people with IDD have very underdeveloped social skills. They've been isolated from others in the community. So if they're living at home, they're very familiar with their family and maybe the close circle of friends, but not necessarily engaged in the community. And if they were living in the community, they may not have developed those social skills because they didn't know their neighbors. Maybe it wasn't a safe neighborhood to live in. So we developed, we have lots of different housing styles, as I mentioned, to help combat those components. We have a group home, which is a high needs home. So the group home that we have 8 gentlemen living in a traditional group home. We have single family homes. We have 3 of those. So those are homes that you and I might live in where 4 roommates live together. That again is a very high needs home. So that has 24-hour staffing. We have studio apartments. That is a semi-independent style. So it's a linear building, 4 apartments in them, but and then a center space, a 5th center space is where the staff is. So a staff is not necessarily in their residential setting at all times, but is available to someone at all times. These are primarily individuals who can live on their own, but this is their first time living outside of their family's home. So that it provides that safety net of staff for them. So if they're burning their mac and cheese and they don't know what to do, then they can call on a staff to come in and help them with that. And then we have 1-bedroom apartments. With these individuals are very independent. We have 2 actually that drive. So they just need someone to check in on them, once a day or a couple of times a week to make sure that they're doing all right. And then we have single room occupancy, and that is the dormitory rooms within the Transition Academy. Next slide, please. A little bit on the design. So this is just a map of the immediate area around. We're actually in Owasso is where this neighborhood is. So this is just to point out that we were very intentional on where we purchased the land and make sure that our residents had access to lots of different things. And then we have some public transportation that's available to them as well. So they don't have to necessarily just call on us to provide that transportation. If they're at a level of independence where that's safe, they can leverage public transportation as well. Next slide, please. A little bit about the design. So again, we're located within Owasso city limits. It was important for us to identify land that was within Tulsa County versus some of the other counties surrounding us because of the resources that are available to these individuals. You can see on the map we're close to 2 hospitals, lots of grocery stores, and retail and entertainment, community amenities. There's a YMCA literally 3 minutes away. And when we designed this, knowing that the majority of our clients don't drive and the residents within this, all of the parking is on the perimeter. We want this to be very pedestrian friendly. This is their neighborhood, not those of us that are serving them. So there's only parking and driving on the perimeter. Shouldn't have to watch out for us that are driving. There are large front porches going back to the pre-1960s design where housing had large front porches and everybody knew their neighbor versus the back patios where it's a little more insular type design. And this has been really excellent for our clients to be able to have those that have similar interests and start to build those relationships with their neighbors. Each building has its own tornado shelter. We contemplated having a central location, but taking into account mobility issues and the mental health component, each building has its own tornado shelter. It's typically the guest bathroom within each building. And there are lots of common spaces. There's a big one in the apartment building to, again, foster those relationship buildings. We have a cafe that's available. It was designed for the students in the Transition Academy, but it's available to anyone who lives in the neighborhood. And we have recently put in a walking trail. There's a walking club that the clients have initiated on their own. There are 2 fishing ponds and lots of outdoor gathering spaces and green spaces and a dog park. Again, just facilitating that meaningful movement. And we will break ground on phase 2, hopefully this fall. And that'll include a community center with a half-court basketball court and workout area and outdoor rec courts as well. Next slide, please. So just a quick idea of the safe, and I've mentioned the safe part, but the affordable part, we leveraged low-income housing tax credits during the construction. So that committed our organization to providing that below market rent. It's usually about 30% of their income is the cap for the next 40 years. The funding from LIHTC was great, but we wanted to make sure we locked in that commitment for our organization. So just an idea of the rent. So a 1,200 square foot 1-bedroom apartment is $560 a month. Then that includes all utilities. So far below almost half of market rent in our area. Okay. And that is all that I have.
Thank you, Miranda. Great presentation, and we are very happy to hear all the services that you are providing. And it seems that there is a question for you that we are going to have a Q&A in the last few minutes of the webinar. In the meantime, we are going to hear from Michelle Garcia, who is the Latinx community organizer at Access Living. Hello, Michelle.
Sorry, I was on mute. Hi, everyone. I'm Michelle Garcia. I'm the manager of community organizing at Access Living. Access Living is a center for independent living. We are one of 400 centers for independent living in the United States. We offer services and advocacy for people with disabilities. Here in Illinois, we are here in the state of Illinois. For those of you who do not know, or who see us from other places, we are one of 21 centers for independent living in the state of Illinois. We're the largest one, as a matter of fact, in the state of Illinois. We are in Chicago, and we serve people with disabilities who are in the area of Cook County. With that said, we, like I mentioned before, do services and advocacy. In these, we have 4 core areas of service that we do. We have advocacy, independent living skills, transition supports, and peer support, as well as, so it's actually like 5 rather than 4. I said 4 before, sorry. And information and referral. So these 5 core areas are very key to the work that we do in all of the areas. In our advocacy, we have policy and organizing. So I am the manager of organizing, like I mentioned before. In our advocacy team, We have 4 organizers, and we have 4, almost now 5 policy individuals who focus on different areas of expertise. The organizers focus on areas of healthcare, housing, racial justice, and immigration. In the policy area, we have education, healthcare, transportation, diversion and reentry, and transportation. Did I say transportation twice? I think I did. I'm so sorry. So 4 or 5 in the policy area, but we all work together basically, because all of these areas intertwine at one point or another. Like for example, healthcare is, if we have housing and healthcare, they obviously intertwine because one is a social determinant of the other. Of course, immigration status, the same thing. Transportation, like the speaker was mentioning before, is also a social determinant of health, and also it impacts your housing and everything else. So definitely. And what we thrive or go based on is that we envision a world free of barriers and discrimination, where people with disabilities are respected and are seen as a natural part of the human experience, right? We are part of society. We are not to be seen as a barrier or as something that is an impediment to this society. We are part of it. We have this motto that says nothing about us without us, meaning if something's going to be spoken about people with disabilities and they're going to be serving people with disabilities should be at the table, right? Because we want to thrive to serve and be a more stronger, inclusive society, because we are part of society. So with that said, I want to focus more on the work that I mentioned we do. So in the areas of housing, for example, I want to shift us a bit to what we actually do at Access Living. Like I mentioned, we do services and advocacy. So in our services side, what we do is that we do INR, which is information and referral, and that INR individual, connects people with disabilities to housing opportunities, which many of the times, unfortunately, especially in Illinois, and I'm sure in other states as well, but there's long waiting lists because there's not much accessible, affordable housing that we can refer folks to. So for example, we work a lot with the Chicago Housing Authority and other entities to ensure that there's, which is where we work through with our advocacy and policy to ensure that there is housing for folks with disabilities. But again, there's long waiting lists. There's needing to push for more vouchers at given points. But these are still ongoing advocacy related issues that are needing to be pushed, and for the ongoing, like increased vouchers, for example, or opening of the waiting lists. So because of the fact that it takes a longer wait period for the system to change in that aspect, we try to hold individuals accountable and try to understand that we are having, and by having folks understand, we kind of also address this with the provider, like the CHA or the housing authority, or HUD, for example, but also the consumer, right? The leaders that we work with, that there is long waiting lists, that we know people are in many instances homeless We have a lot of homeless people with disabilities. We actually right now have an advocacy effort going here in Chicago for inaccessibility of homeless shelters. A lot of folks with disabilities are not able to even access a homeless shelter because they can't get in. And even if they can get in at like because of their ability to, move or walk or whatnot, within the premises, once they're in, they're not able to use the facility to its full capacity because of the inaccessibility, again, of the beds, of the facilities inside, like washrooms, etc. So that in itself, this is why we have, an advocacy effort to ensure that all shelters need to be accessible according to the ADA. So that's one. And so that also increases the other areas of work that we're doing, which are the healthcare fights or healthcare advocacy work that we're doing, because folks who don't have proper housing tend to go to the ER a lot more. ERs are not accessible. Unfortunately, we've had long-standing advocacy battles with ERs because many of them are not properly accessible for folks with disabilities. Many of them whom have mental health disabilities. Many of us, if you're not seeing me, I am a person who uses a wheelchair. So when I go to an ER, I am told to not be in the way, for example, that I need to go to the corner because my wheelchair is in the way. Well, first of all, I'm not in the way. I'm waiting like everybody else. But so they need to make the waiting room or the ER wider, or it makes more space so that everybody can be part of that waiting room area for when you're not feeling well and so on and so forth. Also within the facilities of the ER, they're not accessible. If someone needs to use a restroom, etc. We've noted that they're not accessible when we've brought this up. So bringing those issues again, when I bring them together because they relate, obviously. And so we've tended to see a pattern, an ongoing pattern that people who don't have housing go to the ER because they need it, especially now in the winter. This happens over and over because people need a warm place to stay. And where do they go? Hospitals. So that. And so we need to continue to fight for barrier-free public housing. And we need to make it affordable, accessible housing, of course. So here at Access Living, we have a group, an advocacy group called DRAC, that I am blanking on the acronym of the name of the acronym. I'm so sorry. I was looking for it before this, and I couldn't find it. I'm so sorry. But at DRAC, what DRAC does is that they advocate, again, with the city, with the state, with the county, to ensure that people with disabilities have adequate, affordable, accessible housing at all these different levels. So that's what DRAC does. And then for we also are in many other spaces where we advocate for the right for healthcare and housing for immigrants with disabilities. Like I mentioned, another part of what we do is we work with immigrants, or we do immigration work. So our immigration work stems up because of the need for that intersection of disability and immigration. Right now, we don't do legal services at the moment, but I'm very happy to report that starting next year, we will be. I'm so happy. That's the first for us. So anytime I get to say that, I'm very excited. This will be happening. But for now, we are able to ensure that folks with disabilities have the education on the fact that regardless of their status, they're not supposed to be discriminated against in their area of housing and or healthcare. We have many instances when I get phone calls because I get all the individuals who are immigrants and or Latinx, because that's my area of expertise as well. And they call me when they're like discriminated against by their landlords and or in the hospital, they're not being treated because they don't have insurance. So we let them know, this is wrong. They're not supposed to be discriminated against, or their rent is not supposed to go up just because they don't have, documentation or proper documentation. We've also made sure that we have people backing them up when they've been threatened by ICE or by their landlord to call ICE, which has happened, unfortunately. So ensuring that there's advocates there to support them. So that's what we do on the advocacy and on the services side. Also, we help on the services side. So we help through the Colbert which is a program that helps individuals get out of nursing homes, get into a home in the community for individuals that qualify, obviously. The Colbert class is something that has been super helpful for folks with disabilities who are able to transition or who have the choice, like the previous speaker said, who have the choice of wanting to get out of the nursing home and now going to the community to get their apartments. So we help them with 2 months of rent. We help them get settled, like 2 months of rent, get their furniture, get everything settled into a new apartment, and get them, because many of them have been in a nursing home for like 10, 20 years. I think the most I've heard was 25. One person was in a nursing home for 25 years. So she was able to, she wanted to come out. And so we helped her get out and get housing. And her and her daughter were able to get an accessible, affordable housing. And she's now in the community. So we helped her get out. We helped her get situated in the community. So that's what we look for. We look for those opportunities and we help people thrive in that area. And so that also helps with the health aspect of the folks, right? Once you're settled and you have in your own home and you're part of the community, your health is gonna get better as well.
Michelle, thank you. We are very pleased to hear everything that you're doing, not only as the Latin community organizer, but also your stories about what social determinants of health you are facing as a patient. I know that our people right now who are with us may have additional questions for you. And please stay with us just for a moment. We would like to just turn it over a little bit. We need to hear from Ms. Wilson Kimball as well. And then I'll return to you because we have some questions. You have touched really good points about increased access to care for people with disabilities. And your story, specifically the one in the emergency room, is very important for the health centers attending this webinar. I'm just going to provide some minutes to Ms. Wilson Kimball. Does it work for you?
Hi, thank you, Jose. Can you hear me? Good.
We can hear you.
Okay, I would say, I am from the Municipal Housing Authority for the City of Yonkers. And the theme of our improving healthcare access for people with disabilities is forging non-traditional strategic partnerships. Who we are. Yonkers Housing Authority has 4,700 vouchers in the community, 1,700 units that we own and operate. We're in the city of Yonkers, the third largest city in New York, 210,000 people. It's also the largest city in the county of Westchester. So beginning with our non-traditional strategic partnerships, we partnered with Patterns for Progress, which is a think tank. They did a Westchester housing needs assessment, and that determined that countywide, approximately 9% of the population has at least one disability, according to their survey. They then went on to recognize that 3% of the county population aged 5 to 7 has a disability, whereas 18% of the 65 to 74 year olds have a disability. And they estimated that 2.2% of the county population under the age of 18 had a cognitive disability. So we use that information to do decision-making because we are very keen on providing housing, particularly for seniors. What the housing needs assessment also demonstrated, besides the high rate of disability among our seniors, is the amount of need in the community for affordable low-income housing for seniors. And as everyone else said, if you have a disability, you have a higher rate of potentially being low income because of job challenges and whatnot. So what we did is we took that information, we started building passive house senior housing. Passive house senior housing is the highest level environmental housing. It's quality controlled, the air quality is good. It does not allow for flow between units. So that cuts down on respiratory illnesses, that cuts down on COVID spread, that cuts down on sort of quality of life, aging, health-related problems that are within the air. And also every passive house building has a generator in order to run the building should there be a catastrophic, what we're seeing here in Yonkers anyway, climate change event, flooding, and extreme storms, even in areas that are not flood zones, even in areas that have never flooded before. And so what we found during extreme snowstorms and rainfall is that we couldn't get to, first responders couldn't get to senior housing. And that put seniors at risk, their health at risk, because they might have medication that they needed, they might have some kind of health support that required electricity. And so we are able, with a passive house building, not only to control the air quality, but also to have generators which could support any kind of machines that are needed, any kind of refrigeration for medication and whatnot. So that's one thing that we're doing. In our neighborhood, we have 3 hospitals, St. Joseph, St. John's, and New York Presbyterian, Bronxville. We deal with, or we have noticed a trend in increased mental health conditions since COVID. And so we partnered with the Family Service Society of Yonkers. They have licensed social workers. There are resident coordinators. They're in all of our properties. They help our residents who are struggling or overwhelmed or anxious to fill out their paperwork, to apply for their benefits. We pay for them through our own funding. We converted completely to RAD and LIHTC. Through RAD to LIHTC, and that freed up cash flow, but it made us, it did not qualify us for a Ross grant. So we pay for those social workers out of our own money. We think they're valuable. We would never give them up. And they're the frontline workers who identify for us any potential issues. We also partnered with the City of Yonkers Office for the Aging, who helps seniors suffer from everything from a lack of nutrition, so they provide meals, but also they have received a grant for hoarding. We find that many seniors are hoarders, and that threatens their health in the sense that it creates fire hazards for themselves and their neighbors. It also demonstrates their anxiety, and also it limits their ability to have access to either a nurse or a daycare provider. So we have worked with our seniors on hoarding. We also had some seniors who we were trying to onboard who were having issues coming out of homeless shelters and living in a unit. First, they sort of denied the unit had a kitchen, then they denied the size of the unit. And so the Office of the Aging was able to bring on Alpha Well Care, which was mental health support. So then now seniors will go with their mental health assistant to the showings of the apartments to help them work through any challenges they might have. Believe it or not, that's actually a very big problem among some of the homeless seniors in our community. We also have St. Vincent's Hospital, which provides a 988 hotline, because believe it or not, some of the mental health issues present themselves as bullying. That has increased certainly during COVID. And so we've had, threats to bodily harm. We've had all kinds of bullying. And so St. Vincent's provides a van that will come and intercede, but they also provide a 24-hour, 7-day-a-week hotline for emergent mental health care issues. So we have also worked with our security department and our legal department to help seniors who are facing addiction. We find that there are an increased number of drug overdoses and drug abuse among our seniors. That's one of the highest suicide rates in our county is also seniors. And so we have been working with our legal team and our security team to monitor that and pass that information on to healthcare providers who can then come and service those tenants that need that. We have worked with the Business Council of Westchester. They have a WIN program, which is an innovation program. They have multiple medical facilities like Montefiore and Einstein School of Medicine, who are developing things like tracking bracelets that will anticipate falls that seniors might take and sort of help to regulate that. Also help to let their healthcare providers know that they may be due for a fall, or that certain health statistics, their numbers, their medical health numbers are off, and so they might be more prone or less prone to a fall. We work with Westchester Disabled on the Move. We have an MOU with them to facilitate housing, so we get homeless people into our housing as quickly as possible. We rely on them too to point out areas where we're weak. We have someone who is vision impaired who pointed out to us that the flyers that we put up are not in Braille. The things that we do are not sensitive to her needs. And so we are constantly working to address those situations that we ourselves did not think of. And we're very grateful that we have this partner who helps us point it out. And lastly, we worked with the county and New York State to do a vaccination event. We rented buses, brought in healthcare providers, got our seniors vaccinated, and to the extent that that would be something that would have to happen in the future, we would do that again. We did 700 vaccinations in the first round, and so I'll leave it there.
Thank you so much, Wilson. We had 3 great panelists. We ran out of time, unfortunately, but if you have any questions, and you can stay just for a bit longer, please feel free to add your questions either through the chat or through the Q&A features, and your answer will be, your question will be answered by our panelists. So thank you so much. I also would like to thank the Council of Large Public Housing Agencies for collaborating and partnering with the National Center for Health and Public Housing today's webinar. So it's a great pleasure to work with Camila as well. And we have a quick question, and this is for Miranda. Miranda, the question is, how does the Olmsted decision come into play with the concentration of people with disabilities in the village?
Yeah, so the primary outcome of the Olmsted Act was the settings rule set forth by CMS. But the settings rule, even though settings is in the title, has nothing to do with the setting itself. It's all about the experience, and all of the language particularly with the clarification that came in 2019, has to do with the experience of the individual. And so we are very cognizant that we are creating those experiences and opportunities within the neighborhood, within the community, outside of the neighborhood. And so one of the things that was very important to us is if you live in the neighborhood, you also can't work in the neighborhood. You have to work someplace else. So again, it's not about the setting itself, it's about the experience. And that's how we're not even under heightened scrutiny with our project. It was just approved because we had done so much due diligence to make sure we were adhering to the rules.
Thank you so much, Miranda, for that answer. Also, this is a question for Michelle. Michelle, you brought up not only your experience helping people experiencing disabilities, but also you are someone living with a disability. And what we have here, many health centers right now trying to increase access for people with disabilities. Since you are experiencing firsthand all the limitations and all the complications that you have, and since you brought up something interesting that when you said that people with disabilities should be at the table, what would you recommend to the health centers? What have you seen, and what if I were part of the advisory group of this health center or the board, and I asked the question, what do we need to do to increase access and to improve access to people with disabilities? What your response would be?
Sure. So, my response to that would be, if you have a board or if you have a task force that meets, I don't know, every month or however often you meet to discuss how to improve the services you offer as a healthcare entity, ensure that there's a patient, in this case, like I'm just going to give myself as an example. Ensure that I, as a patient, are at that table, because I'm going to be the impacted individual, which is what we're doing. To the example that I gave earlier about the emergency rooms not being accessible, we were wanting to make sure that the emergency rooms were going to be accessible. So we asked to be at the table when things were going to be discussed, for the betterment of the facilities. So we are now at the table with some entities to discuss how to ensure that all emergency rooms are going to be made accessible. It's not going to be from today till tomorrow, right? It's not going to be quick, but we're at the table now. So if you ask me to be if you're going to make changes that are going to impact me as a patient, I would rather you ask me to be on that task force, board, whatever it is that you have.
Thank you, Michelle. Thank you so much for your answer. And Ms. Wilson Kimball, just a quick question for you as well. Health centers applying or trying to get funds to serve public housing residents, they are required to work closely with public housing agencies. So if you have a health center reaching out to you, trying to improve all the programs and health services that you provide, how the health center could collaborate with you?
Oh, it's very easy. Just anyone can email me, and we collaborate with every kind of, from Alpha WellCare to St. Joe's, St. Vincent's, St. John's, New York Presbyterian. And I think we had even, I can't remember the name of the healthcare group that provided all of our vaccines for us, but we worked with them too. We're very eager to bring care into our properties and help with our seniors, because I firmly believe in preventative healthcare.
Thank you so much. Again, if you have any additional questions, please send your questions, and we are going to make sure that Miranda, Michelle, and Wilson get your questions. We unfortunately we run out of time, but I would like to thank again Miranda, Michelle, and Wilson for this activity and for their experience and for everything that they are doing in the community. So thank you so much for this webinar, and for the attendees, there is a survey after the webinar is over. So please make sure that you complete the survey. And if you have any questions, you can contact any of the members of our team, so are going to be able to help you with any training or technical assistance requests that you have. So thank you so much and have a great afternoon, everyone. Thank you.